Hello and welcome back to Lectures in Anesthesia and Critical Care. This is your host Nahal Saeed. You're probably all familiar with the movie Mission Impossible 3, where one agent is sedated and unable to perform, and another agent picks up a stick of epinephrine, stick it in her heart, and voila, she is back in action, awake, and so forth. This is what we do similar way when we resuscitate patients. Today I'm going to talk about receptor physiology, principles of using vasopressors and inotrops, some practical issue that would help you manage your patients, some pharmacology of the adrenergic agents, pharmacology of vasopressors and other non-adrenergic agents like diphosphoesterase inhibitors. We'll go touch quickly on complication and then the major controversy that face us managing hypertensive patients in the ICU. Alpha adrenergic receptors are mainly found in blood vessels, and they cause vasoconstriction. There also are few of those present on the heart muscle, and they increase the duration of contraction. The exact physiological role of such is not clear. Also, beta adrenergic receptors, beta 1 is inotropic receptor. They cause increased contractility as well as increase chronotropy or heart rate, and they have a minimal vasoconstriction effect. Now, beta 2 receptors have a major vasodilator effect, and that effect is much more than the constriction done by beta 1. Now, if you move to dopamine receptor, they are distributed all over the renal blood vessels, splanchnic, gut, liver, and coronary as well as cerebrovascular vasculature. They mainly, when stimulated, cause vasodilatation. There is a second subtype of vasoconstrictor, dopamine receptors, that cause norepinephrine release, but that's much less important. However, it may be dose dependent. There is also other receptors. We're going to talk about those. Vasopressin had V1, V2, and V3. I'm going to describe those later. And also diphosphoesterase inhibitors like amrinone and milrinone. Those does not have receptors, but they work intracellularly on the GMP system to prevent destruction of cyclic AMP. And then there is also a category of drugs called nitric oxide synthase inhibitors or scavengers, and those are important medication because the thought of using them in critically ill patients, especially septic shock and irreversible shock, is in the spotlight as we speak. So what's important to remember when you're using inotrops and vasopressors? That one drug might work on many receptors. So an example of that is dobutamine. Dobutamine increases cardiac output, and that's through the beta 1 receptors, but also can cause vasodilatation because it stimulates the beta 2 receptors. So one drug can do two effects in two different receptors. Also, dose response curve, and the classic example of that is dopamine. When you start with a low dose dopamine, 1 to 2 mics, it's basically working on the renal dopamine receptors and cause increased glomerular filtration, GFR, and increase glomerular blood flow. And when you increase the dose from 5 to 10, say, you get the beta effect, whereas you get the chronotropy and increased inotropic or contractility. If you go above 10 mics per kilo per minute, you go hit on the the, 10 mics per kilo per minute, you go hit on the, 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 the alpha receptors, and it can cause vasoconstriction. You can see that dopamine is a very versatile drug. It can work on dopamine receptor only, it can work on beta receptors, it can work on alpha receptors. And there is direct effect and there is reflex action that can happen from the effect. For example, norepinephrine is a mixed alpha agent mainly and a little bit of beta effect. It can cause tachycardia from the beta adrenergic effect. However, the vasoconstriction caused by the alpha receptor stimulation causes bradycardia through the brainstem, the vasomotor center, and so forth, and the cardiac accelerator fibers. What is really the goal of treating patients with inotrops and pressors? Really is to restore perfusion to the peripheral tissue. And we don't have a monitor to really tell us how perfusion is restored in patients with sepsis or cardiogenic shock or so forth. So instead, we try to normalize hemodynamics and hope that that would work for your patient. So if the cardiac output is low, augment that to normal. If the blood pressure is low, augment that to normal. If the SVR is low, augment that to normal. And hence, normalize hemodynamic parameters, hoping that that will normalize flow. While this is a very flawed argument, it is what we really do at the moment. The really eternal question is when you're on call or taking care of an ICU or in the OR, the nurse will come and tell you that the patient is hypotensive. Doctor, what would you like to do? And the answer for that is not as simple, because blood pressure is not really the problem. It's some component that makes blood pressure is a problem, and that's what we need to be diagnosing and treating. The heart is actually two pumps in series, as you guys all know. Blood comes from the venous system to the right side. The right side pumps the heart to the lung. The lung has pulmonary vascular resistance. Blood get oxygenated and go back to the left side, and the left side will be the preload of the left side, or the left ventricle, and the left ventricle will push the blood back to the systemic circulation, which is systemic vascular resistance, causing what we call afterload. Our inotrops vasoconstrictors will work on those to tweak down venous capacitance, pulmonary vascular resistance, contractility of the right ventricle, contractility of the left ventricle, and control of systemic vascular resistance as well. So depending on where you need your drug to work, you will choose the drug to do that job. So while the focus of this lecture is hemodynamic support by inotrops and vasopressors, you need to not think that this is the tunnel vision that you should be approaching your patient with, because the patient actually is a whole with multiple organs involved, and adding to that person what deranged physiology went through a surgery, burn, sepsis, and so forth. You can add one surgeon coming telling you that you can do that because I operated on certain organ. If brain surgeon will tell you not to give so much fluids or isotonic fluids only. Somebody who operated on the abdomen will tell you I want to preserve renal blood flow, and somebody who did a liver transplant will tell you run the patient dry. Your patient might have hypotension as well as ARDS, for example, or had just been out of cardiac surgery, and all those things factor will limit your free choice of medication, because you're not just looking at restoring hemodynamics, but also protecting specific organs over others, given the situation that you're dealing with. So don't make it a tunnel vision, because tunnel vision usually will lead your patient to see the light, i.e. patient will probably die. So to continue, what is a practical issue? Volume is an easy thing to get out of the way. If the patient needs volume, give the patient volume. There is some situation that you can't give the volume even if the patient needs it, or you have to be very conservative giving that volume. And that would be patients with ARDS. You run on the dry side, for example. Patient with elevated ICP, you don't want to flood them with fluid because that will increase brain edema. Liver transplant patients, swelling of the graft can cause decreased graft blood flow and hence thrombosis of the hepatic arterial portal vein. Patients with pneumonectomy, we know post-pneumonectomy pulmonary edema is devastating, and if you're going to make an error on volume status, you probably want the patient to be running on the dry side as much as you can. How do you choose and titrate your drug? First of all, when you trying to treat a hemodynamic problem or troubleshooting it, you need to find out what is the primary disorder. If it's anaphylaxis, it's a vasoplegia. You're gonna have to be your first primary target is vasodilatation, so you're gonna have to pick up a vasoconstrictor. In patients with cardiogenic shock, the problem is pump issue. In pump issue, mean you need an inotrope, so you're gonna pick an inotrope, and so forth. So pick up first the primary, and then by inducing the treatment, you might get side effect from the drug you're going to use. For example, if you have a cardiogenic shock patient and you're going to start dobutamine, that will increase cardiac output, but it will also cause vasodilatation. So vasodilatation might need to be treated with an alpha agent like phenylephrine or levofed, and so forth. But start with the primary issue and then manage secondary issues that is even happening by itself or caused by the initiation of the first therapy. How do you give your inotropes and pressors? There's a lot of arguments about that. Some people say certain drug can be given peripherally, especially if you use lower doses or diluted. But I can tell you one thing. If you're going to use any significant amount of vasopressor for a duration more than a few hours, couple hours, then you probably need a central line. It's okay to initiate vasopressor therapy before starting a central line, but go ahead and plan to start a central line as soon as possible so you can switch to those. Extravasation of vasopressor or poor delivery of such with peripheral access might cause devastating issues. Patients lose limbs, and patient might actually die because the drug is not where it's supposed to be. Also, most patients will have tachyphylaxis to the adrenergic stimulation. That's just the nature of the game. Downregulation. You give patients so much epi for so long time, you end up downregulating their beta receptors, and the effect that you are hoping for does not happen exactly the same. It decreases gradually over time. So if the patient is not improving in a reasonable frame of time, then you probably have to be thinking either for increasing dose or supplementing the drugs with other drugs that work in either in similar mechanism or in an alternate mechanism that is not suppressed by tachyphylaxis. Remember that your goal is to restore perfusion, not really to just get blood pressure. Avoiding hypoperfusion. You might want to be able to restore blood pressure by an alpha agent, for example, but if you did not restore perfusion as well or flow, then you are doing disservice to your patient. Also, many of our patients in the ICU will require some sort of sub-Q therapy, drugs that are given sub-Q like insulin and heparin. If you have patients on high-dose vasopressors, skin blood flow is decreased significantly, and absorption of such drug might not be effective enough. So you're going to have to either switch those medication to intravascular route or use different medication, or expect that the results of those medication will not be as much and they might need more. Frequent re-evaluation of your hemodynamic when you start treatment for hypotension, say, or cardiogenic shock, is the key point here is to keep re-evaluating. You're re-evaluating, is your goals achieved? Did you improve perfusion? Did you get the blood pressure to where you wanted? Did you decompress the ventricle? Did you adequately resuscitate the volume? If these goals are achieved, keep checking because you might be able to wean the drugs. On the other hand, is pathology is actually ever changing in those patients, and what might be the primary problem early on might not be the primary problem a day later or so forth. So you probably need to be evaluating those patients on 2 to 4 hour basis early on, and even maybe less frequently after that, 12 hours or a day. But the key here is no patient stays the same. They either get worse or get better, or the pathology changes and you need to change your management. So keep re-evaluating whatever tool you're using to hemodynamic monitoring. If it's a PA catheter, if it's an echo, if whatever it is, just keep at it. Let's start with the medication we're giving your patient. Start with phenylephrine. Phenylephrine is a synthetic alpha agonist. It's causes vasoconstriction, it raises SVR. And most of the time, if you have a normal cardiac function, even with increasing afterload, the cardiac output will be maintained because contractility has a reserve and patient will continue to eject the cardiac output required. However, if you do alpha agonists with decompensated myocardium or systolic dysfunction heart, your cardiac output definitely will drop, and you might end up inducing pulmonary edema, for example, if it's left ventricular failure or elevated of the venous congestion from the right ventricular failure. So again, reevaluation is a good important part here, but pick up your choice of drugs according to the pathology that the patient have. Not all patients are created equal. Norepinephrine or Levophed is mainly alpha 1, but also some beta 1 adrenergic receptor stimulant. Very potent drug, naturally occurring. Noradrenaline or norepinephrine is produced in the body. It causes vasoconstriction, and it can increase cardiac output to some extent, not significantly, but to some extent because of the beta 1 effect. But increasing the vasoconstriction actually causes reflexive bradycardia to counteract that tachycardia effect of the beta receptors. Epinephrine adrenaline is a beta 1 and a beta 2 stimulant, as you all know, but also, especially in a little bit of higher doses, is a potent alpha adrenergic receptor. Low doses of epinephrine, somewhere between 1 and 10. The epinephrine increases cardiac output. The vasoconstrictor effect will not be as much as Levophed because the significant beta 2 stimulation that epinephrine does through the beta receptors. That's why some patients will have much more higher pressure than others because there is a variable response. Epinephrine is a beta 1 receptor agonist, hence increased heart rate as well as predisposed patients to dysrhythmias. This is something you probably need to consider when you're treating your patients, especially if you are going to either prepare to treat this dysrhythmia, if you have to use epinephrine, or choose another drug if you can to treat the primary issue without having to use epinephrine. Epinephrine actually, despite it increases cardiac output, it decreases splanchnic blood flow much more than norepinephrine, which is actually a vasoconstrictor or dopamine. So people think that lactic acidosis might be coming from the splanchnic vasoconstriction, although it was not proven, but also could be coming from the metabolic effects of the drug, or even we really don't know. This is an article that discusses metabolic and renal effects of adrenaline and milrinone in patients with myocardial dysfunction after coronary artery bypass grafting. You can see here that lactic acid rises between, I'd say, 2 to 5, 6, but if you look at standard deviation, it could be up to 7 or so millimoles per liter. This usually response decreases with time, especially if cardiac output and perfusion improves. Could be also part of the tachyphylaxis response to the drug, or a patient is improving. Lactic acid is produced where there is hypoperfusion, and it is cleared by the liver, which is dependent on splanchnic blood flow, and definitely epinephrine doesn't help there, as it is a very potent splanchnic vasoconstrictor. Epinephrine is designed for fight or flight, a drug. So when it was prepare you for that, it's usually a short period of time. You're gonna fight for a couple of hours and then rest, or you're gonna escape, and again in a couple of hours, and then you're gonna go back to the resting state. We use epinephrine days on end, or even sometimes weeks, and that's where you might end up with trouble. Ephedrine is a drug that anesthesiologists use a lot to treat post-anesthesia induction hypotension. A very versatile drug. It's generic. It acts on alpha and beta receptors, and it's actually a direct and indirect drug. So direct means it stimulates the receptor directly, but also has a very potent release of endogenous norepinephrine, called indirect acting. And in patients with abundant stores, or patients who cannot metabolize the release of the drugs, like patients who have cocaine, on cocaine or cocaine toxicity, also patients with pheochromocytoma and so forth, they might be unpredictable. Patients on MAO inhibitors as well react variably to that drug. Ephedrine is a very versatile drug. You can give it IV, you can give it IM. IV usually I give 5 to 10 milligrams at a time. IM I can give 25 to 50 milligrams, and it will take duration of action will be for longer because absorption is slower. Dopamine is one of the oldest drug we still use today. As I told you before, the dose is early on you just get the 1 to 2 microgram per kilogram per minute that give you the renal effects. Renal blood flow is improving. Now 5 to 10 you end up with the beta effect, where you get tachycardia and increased contractility, but it also causes significant dysrhythmias. And also when you raise the dose above 10 mics per kilo per minute, you definitely affect the alpha receptor and cause vasoconstrictor. That's probably explain why dopamine is a very versatile drug. If you don't know the exact problem with a hemodynamic issue at hand, before you put monitoring, if you start with the low dose dopamine 5 mics, that get you the beta effect. If you increase cardiac output, if that was a problem, it's solved. If it's not, patient will continue to be hypertensive, and hence you're going to have to increase the dose. When you increase the dose, you get the alpha effect as well with it, so you increase cardiac output with the beta, and then you're getting the vasoconstriction with the alpha. So you're basically dealing with the two problems at a time that you didn't exactly pinpoint early on. Dopamine is a good drug to start with. You have to make sure that you know what is your primary disorder, so you can be targeting it more precisely. So after you get your monitoring on, you might switch to another agent if that's not what you thought to be. Dobutamine is predominantly a beta-1 agonist, so it increases contractility and heart rate. By doing that, it reduces left ventricular filling pressure usually. It's also minimal alpha and beta-2 effect, which probably also help overall systemic vascular resistance reduction, as well as pulmonary vascular resistance reduction, which plays again a role in reduction of left ventricular filling pressure. The net effect is increased cardiac output. However, because of the mixed alpha and beta-2 effects, it varies between one patient to another. You might get reduction in blood pressure, or you might not. Isoproterenol or isoprel is a beta-1 agonist as well as beta-2. Pure beta, there is no alpha effect at all. So it increases inotropy and chronotropy, and it causes vasodilatation. We used to use it a lot when we used to chemical pace hearts, since invention and popularity of the pacemakers, electronic pacemakers. The use of isoproterenol is very seldomly used, maybe temporarily until you get the pacemaker wires in patient. Definitely the vasodilatation effect is significant since there's no alpha effect at all, and hence you probably want to use an alpha agonist if you're going to use isoproterenol on your patients. Just remember, when you are using those drugs, pheochromocytoma may have excessive adrenergic response to your drugs, so you have to be very careful if you decide to use pressors and inotrops. Idiopathic hypertrophic subaortic stenosis is a pathology where the left ventricular outflow tract is obstructed, and that usually get increased by after-load reduction and or increased contractility, and hence beta agonists are not the best choice in those patients, and it can aggravate the hypertrophic stenosis and make blood pressure and cardiac output drop. Patients who are receiving monoamine oxidase inhibitors, and not too many of them around anymore, but there's still few around, and those patients have extreme sensitivity to vasopressors, so lower doses to start with and titrate accordingly. Here's an article published in 2010 in the New England Journal of Medicine, comparison of dopamine and norepinephrine and the treatment of shock. Since we have multiple drugs available to us, we will always debate which drug is better for which certain condition. And here is just, I'm going to share with you the survival Kaplan-Meier curves. You can see that norepinephrine has a slight advantage over dopamine. However, the P is not significant. So 28-day mortality is comparable between both. The study is multi-center randomized. Dopamine or norepinephrine as a first-line pressor. The primary outcome is death rate at 28 days. Secondary endpoints were number of days without need for organ support, and most importantly, the evidence or presence of adverse events. So 1,600 plus patients, it's a big study. 28 days mortality was very comparable, 52% versus 48%. Odds ratio 1.1. P is 0.1. However, there were more arrhythmic events among the patients who had dopamine. And now, if you don't find positive results, you usually try to mine the data more, massage the data so you can get some finding. Those are usually something you should not be counting on, but here where they found is that if they give dopamine to patients with cardiogenic shock, definitely mortality was higher, and the P was 0.03. So there's a significant difference between using norepinephrine and cardiogenic shock and dopamine. And the adverse events associated with dopamine was probably mostly related to increased oxygen consumption and arrhythmia. So vasopressin and analogs, mainly we talk about arginine vasopressin or ADH, which we use a lot in intensive care and operating room. It's not a much vasoconstrictor in normal physiology, and that's the good thing about that drug. Usually when patients start to improve and does not need it, they don't get hypertensive, they just don't respond to it anymore. And it's dose-dependent response. While most places, including ours, have a fixed dose for vasopressin, really vasopressin is a dose-responsive drug, so you might titrate up or down from the 0.04 classic dosing. The half-life is about 30 minutes. That's why in ACLS you give it every 30 minutes rather than every 5 minutes like epinephrine. It works on three major V receptor, or vasopressin receptor we call them. V1 is really the vasoconstrictor effect, called systemic, splanchnic, renal, and coronary circulation, and that usually works through GQ, G protein, which end up releasing phospholipase C as the mediator. Interesting enough that the V1 receptor also is found in the pulmonary circulation, and it's a vasodilator. So giving vasopressin to your patient will cause systemic vasoconstriction but pulmonary vasodilatation. So pulmonary hypertension might not be a big deal. Also, the V2 receptors is the second receptor, usually mainly on the distal tubule of the kidney, and also on the factor 8 release from the endothelium. Those two works through the GQ, G protein, but instead of releasing phospholipase C, it releases cyclic AMP as a mediator. The third receptor, V3, is not really of importance much to us, but it's involved in ACTH release in the pituitary gland. Here's an article comparing two different arginine vasopressin doses in advanced vasodilatory shock like sepsis. It's a randomized, controlled, open-label trial. This is just to show you that most of the characteristics of hemodynamics between the two doses, 0.033 and 0.067 unit per minute, is outlined. And most of the differences were not statistically significant except those two. The one is mixed venous saturation was slightly higher in the higher dosing, which is unexpected. It's statistically significant, but it's not really clinically significant. The difference between both is very minimal. It's 63 plus minus 10 to 72 plus minus 9. So I don't know if the difference really mattered to the patient. But norepinephrine, on the other hand, use had dropped significantly on the higher doses. So if you really want to decrease the amount of norepinephrine you're using, a vasopressin with an increasing dose would be your answer. I just want to remind you that the molecular similarities between vasopressin and oxytocin are tremendous. It's basically almost the same molecule. And look here, the exact same molecule except this part, which include the difference. And this is only an outline of the vasopressin, terlipressin, and then the desmopressin, which we use for bleeding disorders. Here's another article, vasopressin and its role in critical care. If you want to explore the multiple uses of vasopressin in critical care, this is a very nice review article by Andrew Sherman. Vasopressin, and there is another analog to it, terlipressin, which is not available in the United States but is available in Europe. They are comparing both of those in vasodilatory shock. This is systemic review and meta-analysis of the randomized controlled trials. So they ended up with multiple articles, 105, and they ended up with 9 articles, which included about 1,000 patients, which is a good number. And here you can see that reduction in amount of norepinephrine use when you use vasopressin or its analog is clearly favors the presence of vasopressin. So, and we know that from the previous studies. There's no reason for us to debate that part. Now, if you look at mortality or survival, you can see where there is a smaller difference, but it's all consistent, almost all consistent, toward favoring vasopressin compared to DDAVP. Now, that study was published in 2012. And basically the conclusion was, given that there is a reduction in the amount of norepinephrine use, we know that part, and then there is a reduction in mortality in septic shock as well, without change in adverse events. And the conclusion was vasopressin compared to norepinephrine may also decrease mortality. Now here's the second study, which also a review, meta-analysis of the same, almost same studies, except there's a couple different between the two. And it was published also in 2012 in intensive care, and they started with about 100,000 articles, ended up with 10, slightly different from the previous study. And again, here is looking at mortality in adults, and you can see most of the studies lie actually on the line, and there is one study that is favoring no vasopressin. But because the amount of benefit from the other study did not cancel out the detrimental effect of vasopressin on that first study, it happened to be a washout. So basically, by analysis showed negative correlation between vasopressin and norepinephrine dose. So we know that part again. The conclusion, though, overall was use of vasopressin and terlipressin did not produce any survival benefit. So you have two studies, meta-analysis of previous randomized studies about vasopressin. One tells you there is improved survival. The P was 0.05 exactly. However, the second study does not show any benefit. So you're going to make up your mind. There's no deadline here at this point. Here's another category of drugs, phosphodiesterase inhibitors, or diphosphoesterase inhibitors. Melrinone and amrinone were classic two drugs we use there. Inhibits cyclic AMP breakdown. So catecholamines end up increasing cyclic AMP in the cells, but cyclic AMP is broken down to terminate the effect. Now, phosphodiesterase decrease the amount of cyclic AMP breakdown and hence accumulate the effect of endogenous catecholamine as well as exogenous catecholamine. It's proposed to increase contractility, for example, without increasing oxygen consumption as much as does catecholamine, probably because the lack of chronotropic effect. And less dysrhythmic, again, doesn't have any tachycardia response to it, like dobutamine, for example, or epinephrine, but it's renally excreted. And in patients with renal failure, the drug and its metabolite accumulate, and actually at certain level, toxic levels, it becomes dysrhythmic. So despite it's less dysrhythmic, it could be a pro-arrhythmic drug if it's accumulated to a toxic level. So in renal failure patient, you better off adjust the dose. This is a schematic to show you where is the beta agonist work, beta receptors, converting ATP to cyclic AMP and cyclic AMP phosphokinase release, and that would open calcium channel from the sarcoplasmic reticulum to cause vasoconstriction and increase contractility, as well as increase calcium entry to the cell. Now, phosphodiesterase inhibitors work on inhibiting the breakdown of cyclic AMP to AMP, and hence there you have more pKa and hence more effect of the catecholamine stimulation. Here's a study looking at melrinone and left ventricular relaxation, which is something that is very peculiar about diphosphoesterase inhibitors, since they are not working through the beta receptors, do not have chronotropic effect, and make cyclic AMP more available. They cause also what we call cardiac relaxation, muscle relaxation, much better than any other drugs we know. You can see here, and the summary of the curve is that when you add melrinone, it increased contractility, but the relaxation phase, it looks very similar to normal relaxation before adding an inotrope. The same on this graph. And then the conclusion was melrinone substantially improved left ventricular relaxation in association with an acceleration of sarcoplasmic calcium and ATPase activity, and hence enhanced contractility, or the inotropic effect of milrinone and amrinone. Nitric oxide plays a very important role in sepsis. Vasodilatory shock mediated by sepsis really happen from endotoxins in gram-negative capsule causing interleukin release, and interleukin 2 will cause a macrophage to release interleukin 1 and TNF alpha, and both of them will work on endothelium to cause vasodilatation. I guess that was a protective mechanism. When you have an infection somewhere regionally in the body, the infection will cause vasodilatation to bring more blood and more white cells to fight the infection. However, when we have generalized sepsis, that's a systemic inflammatory response, that vasodilatation is generalized and also mediated by nitric oxide, and it's very difficult to treat sometimes. Nitric oxide synthase inhibitors are a category of drugs that is being tried now, more experimental than not, although methylene blue is an analog of such drugs that are being tested. We use methylene blue, which is methylthioneum chloride, compared to the N-monomethyl L-arginine, which is the classic NOS inhibitor. There's also nitric oxide scavengers in methylene blue might work that way, where it deactivate nitric oxide released by smooth muscle, endothelium and smooth muscle of the blood vessels. Here's a multi-center randomized placebo-controlled double-blind study of nitric oxide synthase inhibitor 546C88. It's an experimental drug. And they did that in septic shock patients. And this is just to show you that the demographic of both groups, those who received the NOS inhibitor and those who did not, are very similar. And summary of where the origin of sepsis are from also is similar. You can see here the mean arterial pressure is definitely higher with NOS inhibitors. Heart rate is lower because you attain higher blood pressure, causing reflex tachycardia, and you're probably using less beta agonist, which can cause chronotropic effect, so your heart rate is lower. Your cardiac index, however, significantly lower in patients who receive NOS inhibitors, and that might be one of the causes that those drugs did not work very well for those patients. SVRI definitely much higher in NOS inhibitor patients, and stroke index is lower because, again, cardiac index dropped the same reason. Mean arterial pressure is slightly higher in the NOS people. But what's more important here is if you look at the Kaplan-Meier survival plots, you see that patients who received NOS inhibitors had a higher mortality compared to those who received placebo. So basically the conclusion is non-selective nitric oxide synthase inhibitor increased mortality in patients with septic shock. So no role for it. We still use methylene blue as a last resort. Sometimes it works, sometimes it doesn't, and probably if it works, it's just time-sensitive issue rather than it's a true value of the drug. Every time you're going to be using vasopressors, you'll have to think about hypoperfusion. You might improve blood pressure by causing vasoconstriction, but that might reduce cardiac output and hence overall perfusion. Also, you want to think about regional perfusion. Some drugs have more splanchnic preference than others and so forth. So hypoperfusion and of globally as well as of the organ of interest should be kept in mind. Most of the beta agonists have dysrhythmic effect, and most of the diphosphoesterase, if they are not cleared by the kidney and accumulate in toxic liver, they can cause dysrhythmia as well. And some of them prolong QT, some of them do other things, and hence arrhythmias is a side effect that need to be always addressed when you're doing vasopressor inotropic therapy. Again, if you are asking the myocardium to work more by pumping more stroke volume, increased contractility, and so forth, ischemia could happen due to increased demand over supply, and hence you might want to consider the demand supply balance also while you're treating your patient. Sometimes those medication could be administered through a central line, which is the way to go all the time in my mind. But if you're giving those temporarily, at least preferably, they might extravasate, and if they extravasate, that can cause tissue sloughing and necrosis. Treatment that should start immediately are sometimes papaverine or phentolamine if it's an alpha agonist to counteract the effects. Also vigilance, whereas if infiltration happens, you should detect that very early and not wait until it's too late. Beta agonists can also increase blood glucose, and hence hyperglycemia might play a role in patients who are already stressed out and might be diabetic to start with. There is a lot of controversies in inotropic therapy, and mostly probably because we don't have solid evidence to guide us through which to use and when to use, and hence I'm going to give you a couple of those. Vasopressin and terlipressin. Well, we don't have terlipressin in the United States, so it doesn't matter to us, but in Europe most of the studies showed no difference between two. Is vasopressin versus norepinephrine, and as I can showed you that vasopressin use will decrease norepinephrine use, and if that's something you think is going to benefit your patient, you do it. However, vasopressin effect on mortality compared to norepinephrine is not proven. As I showed you, two studies, one showed survival benefit, and the other did not. We know that dopamine, however, from the studies we have at this time, that a dopamine in cardiogenic shock might not be the best choice because it increases mortality. So avoid dopamine in cardiogenic shock, which actually was used a lot earlier on. Nitric oxide synthase inhibitors have been tried. We use them as a last resort, but they actually have detrimental effect on survival. So patients who receive them should not have any survival benefit. Actually, they have increased mortality, and hence use of those is not recommended this time unless it's the last resort. Renal dose dopamine has been debunked a long time ago. Had been useful in animals but never been in humans, and actually renal dose dopamine is, I consider it like Lasix drip. Dopamine increase glomerular blood flow and hence increase urine flow. However, it does not protect against renal insufficiency, does not improve renal function, and it might cause hypovolemia, which can cause renal damage if you're not careful about it, because dopamine induced salt loss, which causes diuresis actually. So no reason to use renal dose dopamine for kidney protection at all, by all means, and if you do, just be careful with volume status. Now, what are the optimal doses of many drugs? And most of the drugs, you have a pharmacy chart saying from 2 and so forth. There is not really a maximum dose if you need more. People used norepinephrine up to 350 mics per minute. The horrendous dose. I mean, the recommended doses are somewhere between 1 and 20 mics per minute. If you go per kilo per minute, it's probably 0.05 to 0.2 mics per kilo per minute. It's unclear if there is a survival benefit of norepinephrine at high doses, although some studies and case reports showed that there is successful outcome, but by all means it's not generalizable. In the 80s and 90s, supranormal cardiac index was something explored to improve mortality from shock, and here we doubled the cardiac output. We got cardiac index of 3.5 to 4. We pushed patient to the limit, and most of the studies that done subsequently disputed the value of supranormal cardiac index. We know that low cardiac index or low oxygen delivery is bad for the patient. However, we are not looking for supranormal anymore. We're looking just for getting the cardiac index to normal, to perfusion, closer to normal as possible, but not pushing it to supranormal levels. And that brings us to the conclusion of this talk. If you have any question, I'll be very happy to get them. You can write us at anesthesia.podcast@gmail.com. I'll get your questions, and I promise I will answer those to you directly, as well as on the following podcast. Thanks for listening, and until we meet again, have a wonderful time. And the structure of adrenergic receptor